Hello and welcome to the Practicing Clinicians Exchange podcast entitled Nontuberculous Mycobacterial Lung Disease, Guidance for a Complex, Challenging Condition. I'm Jennifer Faber-Gerling, and I'm a nurse practitioner in the Division of Mycobacterial and Respiratory Infections at National Jewish Health in Denver, Colorado. With me is Dr. Ann O'Donnell, Professor of Medicine in the Division of Pulmonary, Critical Care, and Sleep Medicine at Georgetown University Medical Center in Washington, D.C. Today, we'll be discussing key concepts in the diagnosis and management of nontuberculous mycobacterial lung disease, also known as NTM lung disease. The program is provided for 0.25 ANCC and 0.25 AAPA credits. The 0.25 credits are applicable for pharmacology credit for nurse practitioners. This activity is supported by an educational grant from INSMED and developed in collaboration with the Association of Pulmonary Advanced Practice Providers. To receive your credit for this program, go to pce.is/NTM. Our learning objectives for this podcast are to apply recommended assessments and tests to appropriately diagnose nontuberculous mycobacterial lung disease in patients, summarize current guidelines for the management of NTM lung disease, construct individualized treatment plans for patients with NTM lung disease based on disease and patient characteristics and clinical trial evidence. So, Dr. O'Donnell, it is wonderful to be with you. And to begin our discussion, I wanted to ask Dr. O'Donnell what the appropriate diagnosis criteria for NTM lung disease might be.
Thank you, Jen. So it's very important to follow the 2020 clinical guidelines that were published in a number of journals with the lead author, Dr. Daly, that review the appropriate diagnostic criteria for NTM lung disease. And there's basically three parts to making the diagnosis. One is the appropriate clinical scenario. So the patient presents with cough and sputum production and sometimes constitutional complaints like low-grade fevers, fatigue, weight loss. And then to confirm the diagnosis, you need appropriate radiographic imaging findings as well as microbiologic criteria. So part one, of course, is the patient and how they present. Part two is imaging findings. So that would be generally a CT scan of the chest that shows some features that would be suggestive of NTM lung disease, such as nodular bronchiectasis, tree and bud nodularity with bronchiolitis, or fibrocavitary or cavitary lung disease. And then the third part of confirming the diagnosis is microbiologic. And according to the 2020 guidelines, the appropriate criteria are 2 positive sputum cultures, either spontaneously expectorated or induced, or 1 positive culture from a bronchoalveolar lavage done during bronchoscopy, or 1 positive tissue culture from either a surgical procedure or bronchoscopy. So making the diagnosis is really covering all 3 of those criteria. Jennifer, what do you think some common errors that you see in clinical practice with regards to these issues?
Well, I think the major thing is that microbiologic data and how do you interpret that? I think it's very important to understand what you're going to receive from your lab because you're going to be counseling this patient as to whether they need to be treated or not. So is this mycobacteria, for example, with macrolide susceptible? And how do you know that looking at those susceptibilities? I also think really outlining those diagnostic criteria by providing education to the patient directly as we make this decision as to whether they need to be treated or not. And then upfront, being honest about the surveillance that needs to happen with ongoing sputum cultures to determine where they're at in this treatment.
One of the things I've noticed lately is our radiology colleagues sometimes say that the CT images are consistent or almost diagnostic of NTM lung disease. And that's not true. You absolutely need the positive microbiology to confirm the diagnosis.
I agree.
So let's move on to some key updates to the guidelines for management of NTM lung disease. And Jen, would you make some comments about managing this infection?
Sure. I think the biggest takeaway from the new guidelines was the addition of amikacin liposomal inhalation, or ALIS. And that is to ramp up the therapy for treatment of pulmonary MAC that remains culture positive after 6 months of guideline-based treatment. Our goal with any of these treatment modalities is to achieve culture conversion, and ALIS has been that game changer in that. The other thing is it kind of discourages watchful waiting in the patient that has significant disease and is requiring treatment. It also talks about the severity of disease and adding aminoglycoside as soon as possible to those patients that have cavitary lung disease or severe disease.
Jen, let's review the common monitoring tools that we use when the patients are on these complex antibiotic regimens.
Sure. For azithromycin, some of the adverse reactions that we look for are gastrointestinal, which is essentially we're going to be monitoring with clinical symptomatology, hepatotoxicity, and we will be doing lab work with LFTs, prolonged QTC interval, and we would get a baseline EKG and follow that over time with EKGs. And tinnitus or hearing loss with chronic use of azithromycin or macrolide. Audiograms are used, and then patient report for increasing tinnitus. With ethambutol, we think E for eyes. And so the primary symptom we look for is optic neuropathy. So visual acuity and color discrimination testing are used for that. And I also encourage patients to go online and pull down the Ishikara charts, talk to their optometrist about the fact that they're on ethambutol. The other side effect that we see is peripheral neuropathy, and that is tingling and numbness of the hands of the feet. Sometimes patients don't always associate that with that terminology, and clinical monitoring for that as well. With the rifamycins, we can see cytopenias, which can be detected in a CBC, hepatotoxicity with monitoring liver function tests, and hypersensitivity. And again, that's through clinical monitoring of your patient. With amikacin or the aminoglycosides, we look for electrolyte disturbances, checking calcium, magnesium, and potassium. Ototoxicity is a highlight for aminoglycosides, and audiograms, serial autograms to watch that. Nephrotoxicity, checking a BUN and a creatinine, and vestibular toxicity. And again, that's clinical monitoring. With liposomal amikacin that is inhaled, the patient can experience a cough, dyspnea, dysphonia, vestibular toxicity. Clinical monitoring and close monitoring with your patient is needed. And then ototoxicity. So again, we're checking those audiograms, although this is entering the system in a different way than the aminoglycoside intravenous, and it's treating the airways more topically. It is the same medication with the same side effect profile. And lastly, nephrotoxicity. And again, we're going to be checking a BUN and a creatinine to monitor for that. Dr. O'Donnell, would you have any thoughts about major takeaways from the guidelines for yourself and your practice?
Yes, I would emphasize what you said. There are patients that are appropriate for watchful waiting, but that watching has to be very organized. And once the patient is under your care, they really need to see you on a regular basis. If you are treating the patient with antibiotics or using just radiographic observation. And as you said, the guidelines really do highlight who do need to be treated with antibiotics pretty much right off the bat. And that's patients with cavitary lung disease and patients who are smear positive in addition to being culture positive. Some of the other management concepts that come out of the 2020 guideline is the importance of using airway clearance as a modality in these patients, treating any underlying disease that might be exacerbating these NTM infections, and being very judicious about the use of appropriate antibiotics, particularly because you need to follow these guidelines to get the best outcomes for the patient. Any other thoughts, Jen, about how to monitor patients on antibiotic treatment for NTM lung disease?
I think the biggest thing is establishing expectations with the patient up front, maybe setting that expectation that you would like to see them and follow up either with telehealth or in person every 3 months to review their side effect profile. that you want to hear from that patient, because we're partnering in the success of this treatment, if they are having side effects, so that we can make modifications to their treatment plan so that they remain compliant and that they don't become a treatment failure if they're adjusting their regimen for tolerance. We do have some strategies on how to introduce therapy, such as stagger starting that therapy so that we can determine how they're doing with each individual drug as we add that, that they're getting their blood work done on a monthly basis so that we can make sure that their liver and their kidneys are tolerating this treatment. But the ultimate goal is for them to be able to sustain this complex treatment plan for 12 to 18 months beyond a culture that's negative. And sometimes that's difficult, and we need to kind of work together to achieve that.
Yes, it's very important, as you said, to make sure the patient understands the potential adverse effects of the guideline-based therapy. So the standard treatment for nodular non-cavitary disease is the 3-drug macrolide, rifamycin, and ethambutol. And as you said, for 12 months after sputum conversion to negative. If the patient has non-cavitary disease, the treatment can be given 3 days per week. But if the patient has cavitary disease due to their NTM infection, then the guideline recommends daily antibiotic therapy and consideration of an intravenous amikacin. And then, as you mentioned, for patients who, after 6 months, are still culture positive with MAC, there is the new drug called ALICE, amikacin liposomal inhalation solution, which does provide additional advantage in terms of converting the patient's culture to negative. Any other tricks, Jen, that you've learned over the years to get the patients through these complex regimens?
Well, it's a very good question. Sometimes getting your surveillance sputum cultures are difficult. And that's where I feel like spending time setting that foundation with airway clearance, because the patient could essentially induce their own sputum. And they're sometimes very surprised by that. I get a lot of questions from providers about how do I manage all these potential side effects? And I also hear a lot from community physicians, the treatment is worse than the disease. And I think we have to squash that concept. I feel like that's somewhat of a cop-out, and that if we can help the patient navigate this, we can be successful with this. Every patient is a little different. So looking at the times when they're administering their medications may be a way to kind of curb some of those side effects. I usually have them split their meds, take their azithromycin in the morning, for example, ethambutol midday, rifampin right before they go to bed. If there's issues or problems with ALICE, in the clinical trials, a majority of the patients actually had significant dysphonia. So we can stop the therapy, we can modify the therapy to get them back to full therapy, or I actually recommend them doing their ALICE inhalation in the evening so that they have voice rest overnight. So there are a lot of strategies to help make this successful for the patient.
Yeah, that's great, Jen. I think that these patients are very treatable, that we should lay the ground with excellent education about the disease, the prognosis, and the treatment options, and we'll have success in treating these patients. So I want to thank you, Jennifer, for this great conversation. And just as a final reminder to our audience, don't forget to claim your CE/CME credits at pce.is/NTM. Thank you for listening.